Thank you. On behalf of my co-authors, I'd like to thank the ASCO organizers for including our presentation in this ASCO press conference, again, TROPiCS-02, which is a randomized phase 3 study of the antibody-drug conjugate Sacituzumab govitecan versus treatment of choice, physician's choice in patients with hormone receptor positive HER2 negative advanced breast cancer. All right. So breast cancer, as you know, is the second leading cause of cancer death worldwide, and hormone receptor positive HER2 negative disease is the most common subset, accounting for approximately 70% of this disease. For metastatic hormone receptor positive HER2 positive breast cancer, international guidelines recommend sequential endocrine therapy, starting with first-line endocrine therapy in combination with cyclin-dependent kinase 4/6 inhibitors. However, when resistance to endocrine therapy develops, the next step is sequential single-agent chemotherapy. This is associated with sequentially declining efficacy and increased toxicity. With limited chemotherapy options in later line settings, there remains a high unmet clinical need. TROPiCS-02 is a phase 3 study that was global, randomized, and open label, as well as multi-center, evaluating Sacituzumab govitecan in the later line setting for patients who were heavily pretreated with prior endocrine therapy and chemotherapy for hormone receptor positive HER2 negative metastatic breast cancer. TROPiCS-02 enrolled patients with metastatic or locally recurrent inoperable hormone receptor positive HER2 negative breast cancer. Patients were required to have previously received at least one endocrine therapy and 2 to 4 lines of chemotherapy for metastatic disease. In addition, patients must have received a CDK4/6 inhibitor and a taxane in any setting. Eligible patients were then randomized 1-to-1 to receive Sacituzumab govitecan on day 1 and 8 of a 21-day cycle or single-agent chemotherapy of physician's choice, which included capecitabine, gemcitabine, vinorelbine, or eribulin. Randomization was stratified by the number of prior chemotherapy regimens, visceral metastases, or prior endocrine therapy for at least 6 months, and the primary endpoint was progression-free survival by blinded independent review. Secondary endpoints included overall survival, response and duration of response to therapy, quality of life, and safety. The demographics and baseline characteristics were generally well-balanced across treatment groups. However, it's important to look at the specifics. The median age in the intent-to-treat population was 56 years, and 95% of patients had visceral metastases. The median time from patients' initial metastatic diagnosis to randomization was approximately 4 years. Patients were heavily pretreated, having received a median of 3 and a range of 0 to 8 prior chemotherapy regimens in the metastatic setting. 86% of patients had received endocrine therapy in the metastatic setting for at least 6 months, and 40% of patients had received CDK4/6 inhibitors for more than 12 months. This study met its primary endpoint with a statistically significant improvement in progression-free survival by independent review. Median progression-free survival was 5.5 months in the Sacituzumab arm and 4 months in the chemotherapy arm. The hazard ratio was 0.66 with a p-value of 0.0003, corresponding to a 34% reduction in the risk of disease progression or death with Sacituzumab versus chemotherapy. A subset of these heavily pretreated patients had rapid progression in the first 2 months on treatment. Therefore, we analyzed progression-free survival at several key landmark time points. The Kaplan-Meier curves separated early and were consistent over time, with a higher proportion of patients alive and progression-free at all landmark time points. Progression-free survival rates for Sacituzumab versus chemotherapy were 46 versus 30% at 6 months and 21 versus 7% at 12 months. The safety profile of Sacituzumab in patients with hormone receptor positive HER2 negative advanced breast cancer was manageable and consistent with previous studies. No new safety signals were identified, and the most commonly reported treatment-related safety events were neutropenia and diarrhea. In patients who received sacituzumab, there were 6 events leading to death. Only 1 event was assessed as related to sacituzumab govitecan treatment. No other specific pattern was identified following detailed review of all safety events leading to death, and these events included COVID pneumonia as well as other illnesses. To summarize, the TROPiCS-02 study assessed the safety and efficacy of sacituzumab govitecan in patients with heavily pretreated hormone-receptor-positive HER2-negative advanced breast cancer previously treated with endocrine-based therapy, CDK4/6 inhibitors, and at least 2 prior chemotherapy regimens for metastatic disease. Sacituzumab demonstrated a statistically significant progression-free survival benefit over chemotherapy with a 34% relative reduction in risk of disease progression or death. A higher proportion of patients were alive and progression-free at all landmark time points, with 3 times as many patients progression-free at 1 year when treated with sacituzumab compared to those who received chemotherapy. At the first planned interim analysis of overall survival, a non-significant numeric trend for improvement in sacituzumab treatment was observed, but the results are not yet mature, and further follow-up for overall survival is ongoing with an additional 2 analyses planned. Sacituzumab also demonstrated an overall health-related quality of life benefit with delayed deterioration for fatigue and global health status quality of life scales compared with chemotherapy. The safety profile of sacituzumab was consistent with that in previous studies. Conclusion, sacituzumab demonstrated significant and clinically meaningful benefit compared with chemotherapy in patients with heavily pretreated, endocrine-resistant, hormone-receptor-positive, HER2-negative advanced breast cancer and should be considered a potential treatment in this heavily pretreated patient population. Thank you very much.